Hi, my name is Amy Ford, and I would like to welcome you to Competence in Cancer Care, What the Nurse Needs to Know. Today's focus will be on end-of-life care and survivorship. We will first focus on end-of-life care, and then towards the end of the session, we'll focus on survivorship. Some topics when discussing end-of-life care are included here in this slide. These are some of the issues that a family and a patient would go through, and we will talk about some of these highlighted things such as the grief and bereavement process, education of the family, resources, hospice care, and palliative care. In order for us to understand end-of-life care, we need to have a good understanding of the definitions of what is an advance directive. There are many different types of advance directives, as you see here on the slide, and we'll go a little bit further. A living will is an advance directive that states what type of care or medical interventions the patient prefers or wishes to avoid. How I view a living will or see a living will is that it's a piece of paper that basically starts the discussion for a patient and their family members to discuss what type of care they would want, what interventions they would need if necessary, and what they prefer or what wishes they may want or things that they may want to avoid. So I see it as a good starter of discussions because these are issues that many families in the oncology setting and in other specialties as well in medicine, they may not begin to discuss and they may not know what a patient would want. And so that's why it's imperative that if those discussions have not been made, that a living will is created. The Do Not Resuscitate order is an advance directive that states that the patient refuses any potentially life-prolonging interventions, such as, and you can see here below, CPR, chest compressions, intubation, and defibrillation. The power of attorney is an advance directive where the patient gives power to someone else on his or her behalf to transact all their business transactions when he or she cannot do so because of time or distance, although they may be physically able. So a power of attorney is where the patient is still fully functioning, carrying on their business, but they may deem somebody, such as their spouse, their child, as a power of attorney for their business transactions. For a durable power of attorney, that means that they deem somebody to help them transact their businesses, help them with decision making on his or her behalf, but when the patient is no longer able. Some important definitions for us to understand as nurses taking care of oncology patients is palliative care and hospice care. These are tough decisions that our oncology patients are having to make towards the end of their life. These are ideas that maybe they have heard about. They may have friends or family members that have participated in either palliative or hospice care. There may be lots of questions. There could be some myths out there. And so I think it's important for us as nurses to be advocates for our patients and to help educate them. So palliative care is care that is intended to relieve but not cure, focusing on the symptom management, helping the patient stay comfortable. And we know that hospice care is care designed to provide for the needs of the client and family as they deal with terminal illness. And under Medicare guidelines, they say if a patient has 6 months or less to live, that would make them a good candidate for hospice care. You may see this in your practice every day, but many families will wait till the very end to implement hospice because they believe that that's the only choice they have, where a patient may only have a few weeks or even a couple of days to live. Some things that may be going on with the patient, they may be a metastatic patient that would make them a candidate for hospice care if they basically have metastatic disease, but they decide that they do not want to progress with any treatment and they want to maybe go home to be with their family. Their disease could be progressing with active treatment. Their disease could recur after remission, or they may simply just have a poor prognosis with whatever tumor type they may have. So there are lots of different reasons that families choose hospice care, but we know that it's a great option and that it provides a good benefit for the family. There are several types of hospice care, so I think this is great for nurses to understand that there's not just one type of hospice care. There's the community-based program where you may have a patient that can participate There's inpatient-based programs. Different hospitals have contracts with different hospice care agencies where they may have an inpatient unit for hospice care. There are also inpatient-based hospice teams and many major hospitals, a palliative care team as well. Or there are freestanding hospice facilities. So if a patient decides that he wants to go home, but he may not want to go to his or her own home exactly where they live, but maybe go someplace else in order for them to live their last few days or months, they can go to a freestanding hospice facility. When an oncology patient is at the end of life, we have lots of counseling issues and supportive care that we can help provide for families, and it's important for us to understand the grief and bereavement process, that grief is a person's response to an experience of the loss. They may have feelings of being emotionally numb. They may feel unable to believe that the loss has occurred. They may have a time of mourning along with some depression, and then they may want a feeling of acceptance. With bereavement, that's the state of having suffered a loss and the experiences that follow the death of a loved one. And this is where we as nurses can do great listening. We can put our empathy skills in place and just be there for our oncology families of the patients that maybe have passed on. I would recommend these community resources for you, the National Hospice and Palliative Care Organization, and you can see the websites listed here below. Different groups called HospiceNet, Get Palliative Care, and the Hospice and Palliative Nurses Association. I would recommend these to you all to have as references. So many family members are worried about reimbursement issues, especially related to end-of-life care and hospice. Medicare has a hospice benefit that was passed in 1983 that ensures that all beneficiaries or Medicare patients could access end-of-life care. And like I said in previous slide, is if they have 6 months or less to live, if it's believed that. And then we know that more than 80% of hospice patients are Medicare beneficiaries. With hospice teams and with palliative care teams, we know that an interdisciplinary approach is used, which is the best approach to help caregive for the patient and their family members. That means that the patient is the center of the team, and that what extends from there is the nurse, the social worker, spiritual counselors or chaplains, different types of therapists, pharmacists, and the hospice physician, who helps with ordering specific medicines for supportive care measures. The pharmacists help dispense those. The idea is to take care of the patient as a whole and a family approach, so they're taking care of not only the patient but the family. An interdisciplinary team is the current standard of practice with hospice care. It's goal-directed. It indicates consistency in actions, interventions in the patient's plan of care. It ensures accountability and patient confidentiality, and it meets current legal and regulatory requirements. I think if you were to ask most patients or their families who do choose hospice care, I think a lot of them would tell you, I wish we had chosen this sooner. I wish we had had either a palliative care team in place or the hospice team in place. Some comfort issues that patients have specifically with end-of-life care is pain. And this is the assessment of pain intensity. I would just be familiar with it. And what I would encourage you to understand is that it's important that you consistently use a scale, whichever scale your facility may use, and that you would document their pain intensity. And you can see here there's the verbal pain intensity, and then there's the FACES scale, and each one of your centers uses one, and it's important that we consistently use one so that we can consistently assess their pain and have it documented. With pain, there are culturally specific tools. I believe this is an interesting tool for you all to see. This is a pain scale that was used in Saudi Arabia. It's interesting to note that the pain scale does not go from left to right, but from right to left, from no pain to unbearable pain. Some of you may be familiar with Margot McCaffrey. She is a thought leader in pain management, and she said back in 1968 that pain is whatever the patient says it is, and it exists wherever he or she says it does. And it's our job as nurses to be an advocate for our patients and to help them remain comfortable during their end of life. Different countermeasures for pain that can be used are pharmacologic, and it's the use of non-opioid analgesics and different types of opioid analgesics. Specifically, if we look at non-opioids, the NSAIDs, we know that that's an initial therapy for mild pain. It helps decrease inflammatory mediators. If we use the non-opioids with the opioids, it works synergistically together as a dose-sparing effect. Non-opioids are very helpful with bone pain and inflammation, and we would want to be careful with using NSAIDs with caution in the elderly, and that we could use acetaminophen as an alternative. With the advent of opioid analgesics, we know that those are used to manage moderate to severe pain. They produce analgesia by binding to specific receptors within and outside the central nervous system. If confusion occurs, we can decrease the dose. We must monitor and treat side effects. Often with our pain medication, another comfort measure is constipation that we may be worried about, and so we would want to treat that accordingly and have the physician be aware to make sure that there are other medicines on board to help with the side effects. Synergistically together may be the use of adjuvant drugs such as the antidepressant class, different types of anticonvulsants, and anti-anxiety agents. The World Health Organization developed the WHO ladder, or the three-step approach, and you can see here with a patient, their pain can go from mild to moderate to severe. This is recommendations and guidelines by WHO looking at synergistically using all three of these agents together. Other non-pharmacologic measures for pain that you as nurses taking care of oncology patients can review: just using some simple clean and smooth sheets, soft and supportive pillows, a soothing environment, just a simple massage or a back massage, helping patients position change, and practicing relaxation exercises. It's important for us to understand nonspecific signs and symptoms that may suggest the presence of pain. Most specifically, in patients that are unable to speak to us, they may be cognitively impaired, and they may have some of these symptoms such as frowning, facial expressions that appear grimacing or fearful. They may begin to fidget or eat or sleep poorly, sighing, groaning, breathing heavily. They may have a change in gait or behavior. So it's important for us to recognize these symptoms in order for us to help manage their pain. Specifically, we're helping the family caregiver as well, managing the pain. Who perceives the pain as worse? Is it the actual patient or is it the caregiver? Does the caregiver have a fear of addiction for their patient or their loved one at the end of their life? Do they have fear of uncontrolled pain or a fear of the side effects? So these are lots of myths we can help dispel with our patients. The whole idea is to allow the patient to be the advocate, allow the patient to make the choice as best they can, and for us to make sure that they are pain-free. That's what I love about the WHO Cancer. If you saw at the top of the ladder, it said freedom from cancer pain. We will now transition to the topic of survivorship, and we'll discuss the different concerns and issues that a cancer survivor faces today. A person who has been diagnosed with cancer from diagnosis through the remainder of life is considered a survivor. Dr. Kenneth Miller came out with Seasons of Survivorship. There was a great article looking at different types of seasons of survivorship, and I think this is a great way to understand survivors. First is the acute survivorship, which is the time of diagnosis and treatment. So your patients that are in that acute phase may have feelings of shock, they may have anxiety, they may be scared, and it's definitely through this acute time when they're first diagnosed that we as nurses can help them feel comfortable and just talk with them, listen to them, and be by their side. A patient then moves from acute to transitional survivorship. Transitional is when the treatment has ended, but their survivors may still feel anxious, depressed, and isolated as they engage in watchful waiting to see if the cancer will return. We are straying away from the term watchful waiting and using more of an active surveillance as the term, which is more of a proactive approach. But you can understand that patients, when they are at that transitional phase and they're told, okay, Mrs. Jones, it's time for you now to end your treatment. You no longer have to come to our clinic. We may not have to see you for 6 months or to a year, how that may produce a lot of anxiety for our patients. Sometimes they just feel like they're being dropped off. And so it's very important for us as nurses and practitioners to educate our patients and to help them feel calm and help to decrease that anxiety as best we can when they are towards the end of their treatment. Extended survivorship is the next phase that a patient would move through, and it comes in 3 different forms. A patient can be cancer-free, so they may be undergoing a treatment-free remission. They may have a maintained remission where they're staying cancer-free due to ongoing therapy, or they're currently living with cancer as a chronic advanced disease that requires continued treatment. So you all know that you may have patients in those different phases during that extended survivorship. And then lastly is permanent survivorship, and it has 4 different subgroups, including survivors who are cancer-free and asymptomatic, those that are cancer-free but with long-term or late problems, so they may have late effects, and we're going to look into that. They may develop second cancers unrelated to their earlier treatment, or have secondary cancers related to earlier treatment. So with that comes a lot of symptom management, a lot of care of these patients, and with today's medical technology and where we are, it's amazing how many survivors we have and the problem now that we have with it being more of a chronic disease, and helping to treat those patients and not just leaving them or abandoning them once they finish their treatment. So some survivorship statistics that you may be interested in seeing. It's estimated that there are 12 million cancer survivors today in the United States. 1 in 25 Americans is a cancer survivor. This number will double by 2050. Over 20 million globally are survivors. 3 out of 4 families will have at least one family member diagnosed with cancer. And 66% of adults diagnosed can expect to be alive in 5 years. 61% of those are greater than 65 years of age. This is wonderful because 10, 20, 30 years ago, this topic was probably talked about, but nothing like it is today, where by 2015, a survivorship care plan will have to be in place for every person diagnosed with cancer. There are several issues that survivors may be going through, and you can see here listed that cancer survivorship, we know, begins at diagnosis, that it leads to a change in person's priorities regarding relationships, career, or lifestyle. It's a unique journey for each person, and it can be prioritized into 3 different buckets. And so we're going to look at physical concerns, emotional concerns, and practical concerns. Some cancer survivors are at risk for developing late side effects, which can occur more than 5 years after a diagnosis of cancer because of the related treatments. With the increase in the number of cancer survivors in recent years and the fact that they are living longer after cancer, treatment of late effects is becoming a more important component of cancer care, and so we're going to look at these separate buckets. There are many physical concerns that a cancer survivor faces today, such as a secondary malignancy. That is a different type of cancer that appears after the original cancer diagnosis. According to the National Cancer Institute, cancer survivors have a 14% higher risk of developing a new cancer, which is thought to be a result of previous exposure to chemotherapy and radiation therapy. Cardiomyopathy is inflammation of the heart muscle, and in cancer survivors, it's most often caused by previous radiation therapy to the chest and/or chemotherapy. People ages 65 or older, also who have received higher doses of chemo, have higher risk of heart problems such as congestive heart failure and heart disease. The risk of infection is related to the intensity and duration of cytotoxic and immunosuppressive chemotherapy. A patient may have many risk factors that increases the spectrum of likely pathogens that cause recurrent infections in survivors. Some survivors have been on long-term use of steroids. Those that have received many chemotherapies or have been on long-term immunosuppressive therapy are at an increased risk of infection as well. Chemotherapy also may be related to thyroid insufficiency, and also with sexuality, you see here sterility and pregnancy post-therapy may occur. Damage to a woman's ovaries can occur, which can result in hot flashes, sexual dysfunction, osteoporosis or thinning of the bones, and early menopause. It also may cause infertility in both men and women, but sometimes medications can be used to restore these hormone levels. We know that 1/3 of all cancer survivors report fatigue as a long-term effect of cancer treatment. The cause of a person's fatigue may be due to treatment such as anemia, pain, they may have a sluggish thyroid gland, lack of physical strength, or depression, or may just have no definitive cause. You see here the last bullet point, just the stress and the demand of dealing with cancer can be very tiring and can cause lots of fatigue in our patients. This fatigue is often called the sixth vital sign. We have our 4 vital signs, and then our 5th is considered pain. 6 is fatigue. And this is one that I've specifically had a patient tell me a few years back that she just said, I did not believe how much fatigue I would experience, and I was not aware how debilitating it would be on my life. Some emotional concerns that cancer survivors face today is definitely the fear of a recurrence. The return of cancer is a common fear among most cancer survivors. It may lead a person to overinterpret the significance of minor physical problems, such as a headache or even joint stiffness. It's simply hard to know as a survivor what is normal and what needs to be reported to the doctor. Discussing the actual risk of recurrence with the doctor and the symptoms to report often reduce a survivor's anxiety. Although many cancer survivors describe feeling scared and nervous at the time of routine follow-up visits, these feelings may ease with time. Less contact with the medical team definitely can be a cause for concern because they're not always right there in the clinic being taken care of. They may have different coping mechanisms that they may need some type of counseling, educational interventions as well. Another significant emotional concern is cognitive function and diminished cognitive function. You may have heard the term chemo brain or chemo fog. There's some newer data looking at calling it cancer brain. It may not be related to the chemotherapy, but maybe just to the cancer itself that causes the diminished cognitive function. There are several studies being done looking at the relationship of chemotherapy to chemo brain, and now looking at the cancer itself in relation to this diminished cognitive function. This is a slide that just looks further into cognitive function and chemo brain, and specifically we know how it may impact the patient, the family, and quality of life, that there's no approved treatments at this time, but there are non-specific measures we can take by helping educate and counseling our patients, maybe prescribing some psychostimulants, and then always having them practice exercise and participate in, here for example, yoga and acupuncture. Returning to work is a sign of regaining a normal routine and lifestyle in most of your survivor patients or patients undergoing in the survivorship. We know that about 80% of people with cancer return to work after a cancer diagnosis. Most people need their job and the medical insurance it provides, and unfortunately there can be subtle discrimination in the workplace once someone has returned to work. Many survivors suffer from chronic fatigue and they're unable to go to work full time. But when planning a return to work, it may be helpful to anticipate questions from coworkers and decide how to answer these questions in advance. Coworkers may want to help but not know how. It's important to set limits, and disclosing and discussing a diagnosis is a personal decision. And that's something that we can talk with our patients, help advocate for them as best we can. But we know that unfortunately, with most people having to work for their benefits and to receive insurance, that these can be some stressful issues that our patients may undertake. A new concept that you may be seeing more with survivorship is cancer rehabilitation, and that is looking at improving the physical strength of a patient. It also helps them become more independent and less reliant on caregivers. It helps them to adjust to actual perceived and potential losses due to cancer and cancer treatment. May help them reduce sleep problems, and the overall goal is to lower the number of hospitalizations and to help them to achieve their best. Listed on this slide are different practice guidelines that the National Comprehensive Cancer Network has developed, as well as the American Society of Clinical Oncology. And so I would encourage you all to use these all as a reference for developing survivorship care plans and looking at the different guidelines to help cancer survivors today. This year, the American Cancer Society came out with nutrition and physical activity guidelines for cancer survivors. They can, under these guidelines, they have that they would like for the survivors to achieve and maintain a healthy weight, be physically active, to have at least 150 minutes of activity each week or exercise each week, and that they would stay on a healthy diet with fruits, vegetables, and whole grains. You may have seen in the literature, but there's lots of literature and data looking at physical activity and nutrition post-cancer or post-treatment to help keep our patients in remission. So in summary, we reviewed end-of-life care and the definitions of the different legal issues, looking at living wills, the differences between a power of attorney and durable power of attorney. We looked at the different types of hospice care and the benefits of hospice care for our patients, understanding that grief and bereavement process, that everyone grieves differently and everyone goes through things differently depending on their set of values. Knowing that the interdisciplinary team approach is the best approach for dealing with patients towards the end of life, and understanding palliative care. With survivorship, we looked at the seasons of survivorship from acute to extended. We also reviewed some statistics. We as nurses are making a difference every day in helping our patients live longer. That there are definitely issues that survivors are going through, physical, emotional, cognitive function, lots of different concerns that our patients may have. That by 2015, a survivorship care plan will need to be in place for every patient that has cancer. Cancer rehabilitation programs and looking at surveillance through different types of practice guidelines, and then looking at the American Cancer Society guidelines for nutrition and activity. I would like to refer you to these web resources listed on this slide for further study with end-of-life care and survivorship. Thank you.